Ever brush and floss and still worry that your breath gives you away? Imagine standing close to a friend, talking through lunch, and still catching that faint, stubborn odor you just can't seem to shake. What if a simple kitchen spice, one you might already have in your pantry, could be a helpful, low-risk ally in the short term? Cloves may help by stimulating saliva, providing a strong aromatic compound, and containing eugenol, which laboratory studies suggest can have antimicrobial effects. But before you reach for cloves as a cure-all, it's important to be clear. Cloves are an adjunct. They may help temporarily and can be part of a structured plan, but they are not a guaranteed solution. In this piece, we'll walk through why routine brushing often misses the true sources of bad breath, how to run 3 quick home diagnostic checks to find where the odor likely comes from, and how cloves can fit safely into a short, clinician-minded trial aimed at revealing the cause and improving breath in a predictable time frame. If this sounds like the answer you've been hunting for, subscribe and watch the step-by-step demo linked below to see the techniques in action. Most people assume bad breath is simply a matter of not brushing well. That's understandable. Brushing your teeth is visible, repeatable, and feels productive. But the mouth is an ecosystem, and many of the microbes responsible for breath odor live in places a toothbrush doesn't reach. The characteristic rotten egg smell of bad breath usually comes from volatile sulfur compounds, or VSCs. These are gases produced when certain bacteria break down proteins and sulfur-containing amino acids. Because VSCs are gaseous, they can travel out of places in your mouth or throat where bacteria are sheltered. A dense coating on the tongue, deep periodontal pockets next to the gums, gaps or overhangs around dental restorations, and hidden crevices in tonsils where small calcified deposits, tonsil stones, can form. Outside the mouth, postnasal drip from chronic sinusitis or reflux higher up the digestive tract can carry odorous molecules into the mouth and throat environment. That means the right first response isn't a stronger toothbrush, it's diagnostics. A short, structured self-check can reveal the most likely reservoir so you can target the problem instead of guessing. The 3 checks I teach every patient are simple, safe, and fast: a tongue scraper smell test, a gauze or floss smell test, and a visual tonsil check. Each one is done gently, and each gives a distinct signal that helps triage whether the primary issue is the tongue, periodontal disease, restorations, or tonsil-related debris. The tongue scraper smell test is one of the most revealing and immediate checks. Use a tongue scraper or the back of a clean spoon, start at the middle of the tongue, and gently pull forward to the tip. You don't need force, just contact enough to lift the soft coating away. Rinse the scraper, then smell it. If you detect a strong, sulfurous odor right away, the tongue coating is a likely major source of malodor. People with a thick, white or yellowish coating often have a higher bacterial load on the dorsal surface of the tongue. Those bacteria produce VSCs in the low oxygen environment there. Importantly, this test doesn't tell you that the tongue is the only source, but a positive result suggests that focused tongue cleaning will probably yield rapid improvements, often within days when combined with the right rinses and hydration. The gauze or floss smell test helps identify whether food debris or bacterial biofilm around teeth and restorations is a contributor. Take a clean piece of sterile gauze or use a length of floss and run it along the gum line, especially between the back teeth and around crowns, bridges, or implant abutments. If you notice a persistent, sometimes sour or putrid odor on the gauze or floss, that points toward periodontal pockets, subgingival biofilm, or problematic margins around restorations. These are places where bacteria thrive below the gum line or in inaccessible gaps. They tend to produce a heavier, more persistent type of odor that often requires a dental professional for definitive treatment. A positive gauze floss test presents a different timeline. You may feel some immediate relief with improved hygiene, but meaningful change often requires periodontal therapy and can take weeks to months. The visual tonsil check is the third quick home assessment and is especially useful for people who notice a distinct, intermittently foul smell that seems to originate in the back of the throat. Use a flashlight and a mirror, tilt your head back, and look at the tonsils. Some people have visible white or yellowish pebbles lodged in the crypts, the tiny crevices on the tonsil surface. These are tonsilliths or tonsil stones, and they can trap bacteria and food debris, producing a sulfurous and sometimes very noticeable odor. If you can see small stone-like deposits, avoid picking or prodding them with sharp objects. Gentle gargling with saline can help dislodge superficial debris. If the stones are recurrent or large and cause discomfort, an ENT assessment is appropriate. If none of these 3 checks shows a clear source, that's an important finding too. No visible tongue coating, no odor on gauze or floss, and no obvious tonsil stones suggest the possibility of an ENT or systemic cause. Postnasal drip, chronic sinus infection, reflux, or metabolic conditions that alter breath chemistry. In that case, primary care or ENT evaluation becomes the next step. The power of these 3 self-assessments is that they orient your next actions. If the tongue test is positive, you can prioritize tongue scraping and adjunctive rinses and expect conceivable improvement within days. If gauze or floss suggest periodontal issues, you should still optimize home care, but be prepared for dental evaluation and possibly professional cleaning and periodontal therapy. If tonsil stones are visible, conservative home measures, gentle saline gargles, improved hydration, and careful monitoring are reasonable short-term steps, but recurrent stones may need an ENT consult. In many cases, multiple reservoirs coexist. A patient can have a coated tongue and shallow periodontal pockets, or postnasal drip and small tonsilliths. That's why a diagnostic mindset, test, try, document, is central to getting reliable results. This is where Cloves fit in. You should think of Cloves as a toolkit addition. They may provide immediate, short-lived relief by stimulating saliva, offering strong aromatic masking, and possibly exerting some antimicrobial effect through Eugenol. Anecdotally, many people find that gently chewing a single whole clove for 20-30 seconds increases salivary flow and leaves a warm, spicy scent that helps cover odors temporarily. Mechanism-based explanations suggest that increased saliva helps wash away volatile molecules and bacteria, while a strong aromatic compound like clove can compete with and mask odor molecules, making a social interaction less awkward in the short term. If someone prefers a rinse, a very small amount of properly diluted clove oil swish mixed into a cup of water has been used in traditional and home practice. However, concentrated clove oil can irritate the mucous membranes and must be handled cautiously. Do not swallow concentrated oil. If you choose to try a clove-based rinse, keep it brief and dilute. Avoid prolonged exposure to concentrated essential oils. People with known allergies to cloves, children, pregnant or breastfeeding individuals, or those taking anticoagulant medications should consult a clinician before using clove oil, because there are case reports and mechanistic reasons to be cautious around bleeding risk and mucosal irritation. When in doubt, check with a clinician. Framing cloves as an adjunct also means not abandoning core evidence-based measures. Cloves are not a substitute for tongue scraping, flossing, saltwater gargling, professional periodontal therapy, or ENT assessment when indicated. They can be integrated into a short diagnostic trial to help you bridge the gap while identifying and treating the underlying source. For example, an individual with a clearly positive tongue test might chew a clove after meals to boost saliva while consistently scraping the tongue, and using saline or alcohol-free antimicrobial rinses is recommended. Someone with periodontal concerns might use cloves occasionally to reduce social anxiety about breath while following a dental treatment plan. A person with visible tonsil stones could use a clove to mask occasional episodes while adopting safe gargling and hydration strategies, but persistent or large tonsilliths still warrants an ENT evaluation. A safe, clinician-framed trial helps you separate temporary masking from real change. Short, measurable trials let you know whether your home routine is moving the needle. A 48-hour trial is an efficient diagnostic window, enough time to see whether targeted hygiene measures create detectable improvement in breath, yet short enough to prompt escalation if there's no change. The confidence-building pattern we recommend is simple. For 2 days, follow a strict, repeatable routine aimed at the most common reservoirs. Keep a short log. Write what you did and how your breath smelled at fixed times, upon waking, midday, and before bed. Use the same self-assessment methods: tongue scrape smell, gauze floss sniff, and an honest social test, how your breath smells to you on a clean spoon or to a trusted but non-judgmental partner. If something improves noticeably within 48 hours, you've likely identified a dominant, modifiable source. If not, the pattern of which tests were positive or negative will guide the next steps. To make this concrete without being prescriptive, here's how you might integrate cloves into that 48-hour diagnostic trial while keeping safety front and center. First, commit to baseline checks in the morning before you eat or drink. Perform the tongue scraper smell test, the gauze floss test, and a visual tonsil check. Record your impressions. Then follow the structured care routine for the 48-hour period. Gentle tongue scraping twice daily, flossing once or twice daily depending on individual needs, saltwater gargles twice daily, focused toothbrushing with a standard fluoride toothpaste, hydration, and a brief clinician-vetted mouth rinse once daily, preferably alcohol-free. Include xylitol gum after meals if tolerated, which can stimulate saliva and reduce bacterial adherence. For cloves, place a single whole clove in your cheek and gently bite or roll it for about 20 to 30 seconds to stimulate saliva and experience the aromatic effect. Alternatively, if you prefer a rinsing approach, a brief, well-diluted clove oil swish may be tried cautiously, again, only in small amounts and never swallowed. Between uses, document whether you perceive an immediate improvement in odor and whether that improvement persists beyond the initial minutes. Important safety notes: stop any clove use if you feel burning, stinging, numbness, or irritation. Do not use clove oil undiluted. And consult a clinician for specific concerns, especially if you are pregnant, nursing, allergic to cloves, or on blood thinners. Even within just 2 days, the combination of targeted hygiene plus adjuncts like cloves can tell you something useful. If the tongue scrape smell fades significantly, the tongue was likely a primary source. If the gauze test still smells strongly despite better flossing, or if you see bleeding or deep pockets, dental evaluation should follow promptly. If none of the home checks changes and your breath remains problematic, an ENT or primary care assessment is the appropriate next step. Putting this into practice in the real world, consider Anna. She's a 28-year-old teacher who brushes twice a day but often notices breath issues midday. Her tongue scraper test is strongly positive, a thick, slightly yellow coating and a sulfurous smell on the scraper. She tries the 48-hour diagnostic routine with focused tongue scraping, saltwater gargles, and a single clove briefly chewed after lunch to manage social situations. By the second morning, she reports a noticeable reduction in odor. The tongue scraping seems to have been the major factor, and the clove mainly provided short-term confidence between oral care sessions. Anna's experience illustrates a common scenario. When the tongue is the primary reservoir, focused mechanical cleaning produces relatively quick changes, often measurable in days, while cloves offer a short-lived supportive effect. Marcus presents a different pattern. He's 47, has a history of gum bleeding and irregular dental care, and his gauze floss test yields a malodorous result even after improved home care. Cloves give him a temporary aromatic lift, but the underlying foul smell returns. Here, cloves offered social relief but did not solve the deeper problem. Marcus's case underscores that periodontal disease often requires professional cleaning, periodontal probing, and possibly radiographs to assess bone support and pocket depths. Meaningful reduction in breath from periodontal origins usually takes weeks and coordinated clinical therapy. Leah's story demonstrates an NT-dominant pathway. In her 20s, she experienced intermittent strong odor that was worst in the mornings and accompanied by nasal congestion and a postnasal drip sensation. Her home checks were inconclusive, mild tongue coating but no significant gauze floss odor. An NT exam later revealed chronic sinus inflammation with mucopurulent drainage. For Leah, cloves felt like a short-term social bandage, but long-term improvement arrived only after sinus-directed care. This vignette highlights the importance of not mistaking successful masking for resolution and recognizing when non-oral factors are in play. As you prepare to run your own 48-hour trial, keep a few practical rules in mind. First, make your testing repeatable. Do your checks at the same times each day and document honestly. Second, be gentle.
Tongue scraping should be firm enough to remove coating, but not so aggressive that it causes pain or bleeding. Similarly, saltwater gargles should be brief and comfortable. Do not hyperextend or force any maneuver that causes gagging or distress. Third, treat cloves as an adjunct, not the centerpiece.
Use them to increase saliva and confidence in social situations or to provide a mild antimicrobial aroma, but keep careful watch for irritation or adverse effects. Fourth, note red flags: persistent bleeding, significant pain, fever, unexplained weight loss, swollen lymph nodes, or any systemic symptoms warrant prompt clinical evaluation rather than further home trials. Now, let's outline a concrete, step-by-step approach you can follow for the first 48 hours so your trial is structured and data-driven. Start on a morning when you can complete the routine consistently and create a simple log. Column 1 for time of day, Column 2 for interventions performed, and Column 3 for your breath rating and any sensations. Begin with the baseline checks before any oral intake. Then, maintain twice-daily tongue scraping and twice-daily saltwater gargles, floss at least once daily, brush with fluoride toothpaste morning and evening, manage hydration, and use xylitol gum after meals if you tolerate it. Introduce clove use as needed for social moments, brief whole clove chewing, or a cautious, well-diluted rinse for those who prefer a mouthwash-type approach. Record your impressions at fixed intervals. At the end of 48 hours, review the log. Which measures correlated with noticeable improvement and which did not? We'll walk through an exact timeline and sample log entries next, showing how a typical morning, midday, and evening routine looks and how to interpret changes across the 2 days. Before we get into that level of detail, it's worth pausing to reinforce the safety boundaries. Do not attempt to dig or scrape tonsil stones with sharp implements. Do not use concentrated clove oil. Do not stop prescribed medications. If your trial shows no improvement or if you encounter any worrying symptoms, prepare to use the clinician scripts we provide to book a dentist, an ENT, or your primary care clinician. The next section will give that precise timeline, sample wording for clinical appointments, and a checklist for red flags so you can move from self-care to professional assessment without delay. Here's a practical, timed plan you can use today, plus examples of how to log and interpret what you find. Begin by doing the baseline checks first thing in the morning before eating or drinking. Perform the tongue scraper smell test, the gauze or floss smell test, and a quick visual tonsil inspection. Note your impressions precisely. Was the tongue coating thick and white, or thin? Did the gauze or floss pick up a sour or putrid smell? Were there any visible pebbles in the tonsil crypts? Use a simple 0 to 5 scale for your breath rating at each time point. 0 equals no noticeable odor, 5 equals very strong odor. Record any symptoms that accompany the odor: dry mouth, sore throat, nasal congestion, reflux symptoms, or bleeding gums. That baseline snapshot is your starting point. On day 1, follow a repeatable routine so your results are comparable.
A practical morning routine might read like this in your log. 7 a.m. baseline checks before coffee. Tongue scrape positive, score 4. Gauze test mild odor, score 2. Tonsils visually clear. Interventions performed: gentle tongue scraping, then brush with fluoride toothpaste, saltwater gargle 10 to 15 seconds, drank 12 ounces water, used xylitol gum after a quick breakfast, chewed a single whole clove for social confidence at 9:30 a.m. Subjective breath rating at 10 a.m., 2. Note any irritation from clove chewing, none. Midday entry might say 1 p.m. Flossed before lunch, gauze test now minimal, score 1. Tongue scrape lower coating, score 3. Evening entry, 9:30 p.m. Repeated routine before bed. Tongue scrape 2, gauze 1, tonsils unchanged. Subjective improvement from morning 4 to evening 2. That pattern suggests the tongue was a major contributor and responded to targeted cleaning within hours to days. The clove provided temporary masking between hygiene episodes. If you choose to try the brief clove chewing technique during the 48-hour window, do so sparingly and with attention. Place a single whole clove between the cheek and gum or gently bite it to release flavor for roughly 20-30 seconds. Then remove and discard. Notice whether the immediate, short-lived aromatic change persists beyond the first 5 to 10 minutes. Document whether the sensation is merely masking the odor or whether you perceive a sustained difference when you repeat the tongue gauze checks later. If you prefer a rinse sensation, a tiny amount of clove oil, very well diluted in water and used as a brief swish, is reported anecdotally in home practice. If you take that route, keep exposure short and stop if you experience burning, numbness, or irritation. Do not swallow concentrated oil. If you feel any mucosal reaction, discontinue and consult a clinician. If you are pregnant, breastfeeding, allergic to cloves, or taking anticoagulants, check with your clinician before trying clove oil. At the end of 48 hours, look at your trend rather than individual moments. Ask, did the tongue score drop consistently? Did the gauze floss odor reduce? Did the visible tonsil picture change? If the tongue scrape improved notably and other measures improved or were low to begin with, you have likely identified the tongue coating as the dominant source. Continue the tongue-focused routine and consider the 2-week extension to ensure durability. If floss gauze smells persist or bleeding is notable, arrange a dental visit. Periodontal disease or a problematic restoration is likely. If all oral checks were low and the odor persists, schedule a primary care or ENT evaluation as the next step. Expanding the window to a 2-week structured routine gives you more resolution to separate transient masking from real, sustained improvement.
Over 2 weeks, adhere to a stable daily pattern: tongue scraping twice daily, gentle brushing morning and evening, flossing once daily, or as directed by your dental professional, saltwater gargles twice daily, hydration goals, target at least 1.5 to 2 liters of water per day unless your clinician advises otherwise, xylitol gum after meals when tolerated, and 1 short alcohol-free mouthwash use once per day if desired. Use cloves as an intermittent adjunct for social confidence. Chew a whole clove briefly before known interactions, or use a cautiously diluted clove rinse only if it is well tolerated. Keep a short daily note of your 0 to 5 breath score and which checks were positive that day. At the end of 2 weeks, graph or list the average morning, midday, and evening scores for each day. A downward slope supports treatment success, while a flat line or worsening suggests the need for professional assessment. One way to interpret the 2-week pattern: rapid decline in scores during the first 48 to 72 hours that then stabilizes at a low level suggests a tongue dominant source that responds quickly to mechanical cleaning. Gradual improvement across days to weeks, but not immediate relief, often indicates deeper periodontal disease, problematic restorations, or slowly resolving inflammation. No improvement at all across 2 weeks, especially if the in-clinic checks are normal, suggests non-oral origins and is the signpost for further medical workup. Now let's look more closely at each major reservoir and the practical signals and timelines you can expect. The tongue is the most forgiving reservoir from a timing perspective. Because the dorsum of the tongue provides a large, uneven surface where bacteria and debris accumulate in a low-oxygen environment, targeted mechanical removal rapidly alters the habitat those bacteria occupy. With diligent tongue scraping twice daily and appropriate rinsing and hydration, many people notice meaningful reductions in VSC-related odor within 2 to 5 days. To get that effect, be consistent. Gentle but firm scraping that removes the soft coating is more valuable than aggressive scraping that causes soreness or bleeding. Adjuncts that may help include alcohol-free antimicrobial rinses used briefly if recommended by a clinician, xylitol-containing gum to stimulate salivary flow, and maintaining adequate hydration. There is some emerging mixed evidence for oral probiotics aimed at modulating the oral microbiome. Results are variable and not universally recommended as a first-line self-treatment. Cloves fit well here as a short-term adjunct. By increasing saliva and offering aromatic masking, they can make social interactions easier while mechanical cleaning does the real work. Expect to reassess and continue tongue cleaning until low scores persist consistently over several days.
Periodontal disease, periodontal pockets, and subgingival biofilm present a different timeline and require different expectations.
When the gauze or floss smell test is strongly positive, or you notice bleeding, receding gums, tooth mobility, or chronic gum inflammation, the odor is less likely to resolve with home care alone. Improved home hygiene, flossing, interdental brushes, and better toothbrushing can reduce surface biofilm and may produce some relief over a few days to weeks, but deep pockets and subgingival calculus need professional intervention. A dentist or periodontist will perform a full periodontal assessment, charting pocket depths, probing for bleeding on probing, and taking radiographs to evaluate bone loss. Treatment commonly involves scaling and root planing, professional subgingival debridement, and in some cases, adjunctive local or systemic therapy is used. Healing and the corresponding reduction in breath odor often unfold over weeks to months as inflammation subsides and tissue health improves. Cloves in this scenario are primarily a social adjunct, useful for short-term confidence but unlikely to change the underlying pathology. Problems related to dental restorations deserve attention because overhangs, open margins, and ill-fitting crowns or bridges create niches for food and bacteria that a toothbrush cannot clean. If your gauze floss test is positive around a specific restoration, or you notice persistent localized odor near a crown or bridge, imaging and a dental exam focused on restoration margins are appropriate. The dentist may remove and replace the restoration, adjust occlusion, or smooth overhangs so that home cleaning can be effective again. As with periodontal disease, substantive odor improvement after restorative correction may be measured in weeks once the restorative issue is resolved and the soft tissues heal. Tonsilliths form in the crypts of the tonsils where food debris and bacteria accumulate and calcify. These can cause intermittent, strikingly foul odors. A visual tonsil check that reveals white or yellowish pebble-like deposits strongly suggests tonsilliths. Conservative, safe home measures include regular hydration, gentle saltwater gargles after meals, and improving oral hygiene overall. Warm saline gargles loosen superficial debris. Avoid vigorous attempts to extract stones with fingers or pointed objects. For people with recurrent, large, or symptomatic tonsilliths, those causing persistent halitosis, chronic sore throat, or frequent gagging, an ENT evaluation is warranted. ENT specialists can offer options ranging from in-office removal under visual guidance to more definitive procedures for recurrent, troublesome stones. Cloves may help here as an immediate masking tool, but they do not remove calcified material. The long-term solution depends on ENT-directed care when stones recur. When oral checks are unrevealing, or when symptoms point beyond the mouth, ENT or primary care assessment becomes essential. Postnasal drip associated with chronic rhinosinusitis often sends protein-rich secretions into the oropharynx, where bacteria break them down and produce malodorous compounds. Symptoms that point to sinus or ENT involvement include chronic nasal congestion, thick nasal drainage, throat clearing, and the sensation of mucus dripping down the back of the throat. ENT evaluation may include nasal endoscopy and, if indicated, sinus imaging such as a CT scan. Management can involve topical nasal steroid therapy, saline irrigations, treatment of underlying infection if present, and, in some cases, procedural interventions for chronic sinus disease. Tonsillitis, chronic or recurrent, may also require ENT input, especially for recurrent tonsilliths or symptoms that impair quality of life. Systemic causes are uncommon but important to screen for because they change the approach completely. A fruity acetone-like breath should prompt consideration of ketosis or uncontrolled diabetes and merits prompt primary care testing. Capillary glucose and HbA1c are typical first steps. A persistent, ammonia-like or fishy odor could indicate renal dysfunction. Hepatic disease can produce a musty, sweetish odor known as hepatic fever. Chronic reflux and laryngopharyngeal reflux may bring gastric contents or volatile odorous molecules into the throat, aggravating halitosis. A careful medication review is also part of the systemic screen because many drugs cause dry mouth, which increases risk for odor. Anticholinergics, some antihistamines, tricyclic antidepressants, and certain antihypertensives are examples.
If home checks and the 2-week trial show no improvement, share this pattern with your primary care clinician so they can order targeted labs, metabolic panel, renal function tests, liver enzymes, and glycemic markers. Avoid stopping any prescription medication on your own. Instead, document your findings and request a clinician-led review. Equally important to knowing what to do is knowing what to say when you reach out for professional help. Clinician scripts make appointments efficient and focused. If you are contacting a dentist, an effective script begins with the key observations and the timeline. Hello, I've had persistent breath odor despite regular brushing. I performed self-checks. My tongue scraper shows a thick coating and a sulfurous smell. My gauze floss test is mild. I tried a 48-hour routine including tongue scraping and saltwater gargles with some improvement, but the problem persists. Could you evaluate for periodontal pockets, check my restorations for overhangs or leaking margins, and take radiographs if needed? That succinctly gives the clinician the diagnostic context and the interventions you've already attempted. If you are making an appointment with an ENT, use a similar, focused approach. I've had ongoing bad breath that doesn't improve with oral hygiene measures.
I have intermittent postnasal drip and sometimes see small white deposits at the back of my throat. I completed a 2-week home trial without satisfactory improvement. Could you evaluate for chronic sinus disease, tonsillitis, or other ENT causes and consider nasal endoscopy? That signals NT-specific concerns and helps them triage appropriately. For primary care, frame your concern around systemic possibilities and medication review. I have persistent halitosis that has not improved with 2 weeks of targeted oral care. I'm worried about possible systemic causes. Could you review my medications for dry mouth contributors and run basic labs such as a metabolic panel, liver tests, renal tests, and an HbA1c? If you have symptoms like excessive thirst, unexplained weight loss, swelling, or changes in urine output along with a distinctive breath odor, convey those to the clinician as potentially urgent clues. When you get to the clinic, expect objective testing to shape the plan. A dentist will likely perform a comprehensive oral exam, probe pocket depths, chart bleeding on probing, and review restoration margins and occlusion on suspect teeth. They may perform full-mouth radiographs to assess bone levels and look for apical or periodontal pathology. A periodontist might recommend scaling and root planing or more advanced therapy depending on pocket depths and attachment loss. An NT will inspect the nasal passages and pharynx, often with a flexible endoscope, and consider imaging when sinus disease is suspected. A primary care clinician will order appropriate blood work and review medications and may refer you for specialist care depending on findings. There are some red flags where home self-care is not the right next step and you should seek more prompt medical attention. Significant unexplained bleeding from the mouth, persistent fever, rapidly enlarging or painful lymph nodes, sudden or severe throat pain, unexplained weight loss, or new difficulty breathing or swallowing require urgent assessment. Likewise, if breath odor is accompanied by signs of systemic illness, confusion, persistent nausea and vomiting, or marked changes in urine output, seek care promptly. These signs may indicate more serious infections, metabolic derangements, or systemic disease. Let's return to the vignettes and extend them into realistic 2-week outcomes so you have tangible expectations. Anna continued her regimen for 2 weeks. After day 2, her morning tongue scrape score had fallen from 4 to 2 and stayed at 1 to 2 for most days thereafter. She used whole clove chewing sparingly, primarily before parent-teacher conferences and social interactions, and experienced no mucosal irritation. By the end of 2 weeks, she reported sustained confidence without needing cloves daily. Her case is instructive. For tongue-dominant halitosis, persistent but non-invasive mechanical care produces durable results within days to a couple of weeks.
Marcus completed the 2-week trial with minimal change in his gauze floss scores, and continued bleeding prompted his dental visit. Radiographs revealed moderate bone loss and probing depths that warranted scaling and root planing. He received professional subgingival cleaning and was placed on a 3-month periodontal maintenance schedule. His halitosis improved gradually over several weeks as inflammation receded. Cloves were helpful socially during the interim, but were not a solution to the periodontal disease itself. Marcus's case highlights that when the biofilm extends below the gum line, clinical therapy is often the turning point. Leah followed a 2-week oral-focused trial with negative results and persistent nasal symptoms. Her PCP referred her to ENT, and nasal endoscopy demonstrated chronic sinus inflammation with mucopurulent drainage consistent with chronic rhinosinusitis. After a regimen of targeted sinus care, including saline irrigations and topical nasal steroid therapy, the post-nasal drip decreased and her breath odor improved. Cloves continued to provide a short-term mask for a few lingering episodes, but were never a substitute for sinus-directed care. All 3 cases underscore the diagnostic first approach: test, trial, and then escalate. Cloves worked as a short-term adjunct for social confidence in each example, but were not the primary treatment for any structural or systemic cause. You may be wondering about over-the-counter or in-office antiseptics and where they fit. Antiseptic rinses such as chlorhexidine can reduce oral bacteria load effectively, but their use should be limited and clinician-guided because of side effects: taste disturbance, staining of teeth, and alterations in the oral microbiota with long-term use. When prescribed for a time-limited clinical indication, they can be helpful as an adjunct to mechanical cleaning. Alcohol-containing mouthwashes may transiently reduce odor but can contribute to dry mouth for some patients. We tend to favor alcohol-free formulations for routine daily use. Xylitol-based products are useful because they stimulate saliva and reduce bacterial adherence. Sugar-free gum after meals is a reasonable, low-risk adjunct. A few practical, dignity-preserving everyday tips round out the plan. Carry a small water bottle and sip regularly to avoid dry mouth, especially during long meetings. Chew sugar-free xylitol gum after meals when feasible. Keep a tongue scraper in your bathroom and use it consistently at a set time each morning and evening. If you intend to use cloves for social confidence, try them first in a single, controlled dose to ensure you don't have a mucosal reaction. Avoid masking strategies that make you anxious about the underlying cause. Use short-term adjuncts while you do the diagnostic work that leads to lasting resolution.
Now, here are some suggested, clinician-ready phrases you can copy and paste into an appointment request, tailored to each specialty. For a dentist, I've been experiencing persistent bad breath that did not improve after a 48-hour and subsequently a 2-week home trial of focused tongue cleaning, flossing, saltwater gargles, and hydration. My tongue scraper remained positive, and my gauze floss test indicates malodor near the molars. Could I schedule a periodontal evaluation and radiographs to assess pocket depths and restoration margins? For ENT, I have ongoing halitosis that does not improve with oral hygiene. I experience postnasal drip and intermittent nasal congestion. 2 weeks of oral targeted care produced no lasting improvement. Could I be evaluated for chronic sinus disease or tonsillar pathology? For primary care, persistent halitosis has not responded to 2 weeks of targeted oral care. I would appreciate a medication review for dry mouth contributors and basic labs including metabolic panel, liver tests, renal function, and HbA1c to screen for systemic causes. When you get to the appointment, it helps to bring your 2-week log or photograph any visible tonsil findings. Objective documentation makes the visit faster and keeps the diagnostic focus sharp. For example, a chart showing morning scores falling from 4 to 1 is compelling for a tongue-based improvement. Stable or worsening gauze floss readings despite home care strongly point to periodontal or restorative issues. Say plainly what you tried and for how long. Clinicians appreciate that clarity. Before we close, let's be explicit about the safety profile and limitations of clove use so you can decide intelligently. Clove oil contains eugenol, which in laboratory settings shows antimicrobial properties. That mechanistic data is part of the rationale behind its anecdotal use. However, concentrated clove oil is a potent agent that can cause mucosal irritation, numbness, and, theoretically, interact with blood clotting processes. Because of that, clove oil exposure should be minimal and dilute when used as an oral rinse, and concentrated essential oil should never be swallowed.
Children, pregnant or breastfeeding individuals, and people on blood-thinning medications should consult their clinician before using clove oil. Whole cloves chewed briefly are generally lower risk than concentrated oil, but still deserve caution. Stop immediately if you feel a burning or numbing sensation. In every case, cloves are an adjunctive measure for temporary comfort and should not delay professional assessment for structural or systemic causes.
To summarize the practical flow you can follow starting now, perform the 3 baseline checks in the morning. Implement a structured 48-hour trial that includes twice daily tongue scraping, daily flossing, saltwater gargles twice daily, hydration, xylitol after meals, and cautious clove use as needed. Log your scores consistently. Extend to a 2-week routine if you need more data. And finally, escalate to a dentist, ENT, or primary care clinician if your logs show no meaningful improvement or if you encounter any red flags. Keep in mind the expected timelines: days for tongue-related improvement, weeks to months for periodontal or restorative issues, and variable timelines for ENT or systemic causes depending on the intervention. If you'd like a hands-on demonstration of safe tongue scraping, a guided saline gargle, and the brief clove chewing technique I described, we have a step-by-step demo that shows exactly how to perform these maneuvers comfortably and gently. Watching it can make your first attempts feel straightforward and secure. And if your pattern suggests periodontal disease or a non-oral cause, use the clinician scripts provided to make an efficient appointment so you don't waste time on treatments that won't address the underlying problem. Remember, bad breath is common and often fixable, but the right solution depends on accurate diagnosis. Cloves can be a pragmatic, low-risk adjunct that buys you short-term confidence while you do the diagnostic work. They are rarely the whole answer. Test methodically, document honestly, and seek professional help when the pattern points away from simple, self-manageable causes. If this guide helped, watch the hands-on demo now for practical technique, and if your symptoms persist despite the structured trial, use the clinician scripts to book an appointment so you can get the precise care you need.